Should we move on to D1b?
Great.
Hannah?
That sounds great.
Okay. All right, great. Well, so we'll move on to D1b. So D1b, which is really focused on capturing the etiological diagnosis and capturing, if and when that diagnosis is supported by biomarkers. And so, distinctly different from assigning a syndrome here, but moving from, all right, we've captured the syndrome, and now we are, asking the question of what is driving that syndrome etiologically and what's our basis for it. Is it clinical alone, or is it clinical plus biomarkers? And so, this idea of splitting the form D1 from, clinician diagnosis, the current splitting it up a little bit more effectively, I think, and sort of independently assigning these categories for syndrome and then etiological diagnosis. So what is the purpose of this D1b? It really is focused on assigning an etiological diagnosis and then documenting, if biomarkers are used to support or exclude. So that's important too. Biomarkers used to exclude a diagnosis, and then based on local standards, and that's important. Why is that important? Because this form is not, this is also important. This form is not intended, not designed in any way to capture biomarker values or indicate if biomarkers are available or how they were done, and in terms of what platform and et cetera, what the cut points are. That is a much more complex question that I know the biomarker committee's working on. This is really about documenting the support for a diagnosis. What information was used to support the diagnosis? Why would we do that? Well, why is that important? Future researchers, current researchers want to understand, want to know when an etiology was, how it was determined. Is it clinical grounds alone, the way we've been doing it for years and years, or is it clinical grounds plus biomarker support? And so by sort of breaking these forms up and designing them the way we've designed them, we think, we've created a way to really more effectively delineate these things and understand better how a diagnosis was assigned. So how's D1b organized? It's basically organized first as biomarkers and imaging, so documenting when that information was used, and then an etiological diagnosis is assigned. So two sections, biomarkers and imaging, followed by the etiological diagnosis. So how are we breaking up the biomarkers and imaging? First, we're looking at what were fluid biomarkers used, blood or CSF. Was imaging done and used in the assessment of an etiology? That's PET or SPECT, tracer-based FDG or DAT scans, and then structural MRI or CT. Was it used in supporting the diagnosis? There's a section for other to try to allow us to have some flexibility as biomarkers move forward rapidly, as we know they will and are, so we can capture stuff that is not sort of captured right now. And then autosomal dominant genetic, an indication of when we have support for an autosomal dominant genetic cause. Then the etiology basically moves through, Alzheimer's, Lewy body. I'll show you this in a second, but FTD or FTLD, and then vascular cognitive impairment. So that's the organization of the new form, the new D1b form. So let's get into it. I'll show you the big picture view, and then we'll zoom in on these. So it's broken up into section 1, biomarkers and imaging, fluid biomarkers, followed by the blood-based and CSF markers, imaging, followed by PET, SPECT, and structural imaging, and then other biomarker modalities, and then one question of supportive genetics that I'll zoom in on in a sec. And then moving into section 2, which should look pretty similar, but with maybe reorganized and redesigned a little bit. But what's the etiological diagnosis? and is it present and primary contributing or non-contributing. So, what's new? Again, we've split these forms up. We believe we've improved the flow. We've added skip logic. If you're in electronic environment, I think this will move much more quickly and much more easily than the current form. And then we've tried to create some flexibility in how we report the supportive biomarker results and how we can keep up with the other section with changes in the biomarker field. So let's kind of zoom in on this now. At the top, basically, the question is, were any biomarker results used to support the etiological diagnosis? If the answer is no, we jump over everything and go straight to the etiological diagnosis, which can be made without biomarkers. And that's how we've been doing it. So you can assign an you need to assign an etiology, presumed etiology, whether you have biomarkers or not. So if you don't have biomarkers, and now this doesn't mean your center doesn't have them. This just means in the assessment of the diagnosis, either it wasn't available, or you may have it, but it's not available, but it's not being used, wasn't used at consensus or at the clinician assessment, to support the diagnosis. So if the answer is yes, then we move into the next question of fluid biomarkers. Sorry, here. I'm getting lost here, which means you're getting lost. So let me just work through this. So if the answer is yes, they were used, then the question is, were fluid biomarkers used? If the answer is no, we move to imaging. If the answer is yes, there's two questions actually. Was CSF used only, blood used only, or both? Both blood and CSF, which would then open up in an electronic environment these questions here, blood-based biomarkers. If blood-based biomarkers were used, the question is simply, is it per your local standards? Were the results consistent with AD, consistent with FTLD, consistent with LBD? Yes, no, indeterminate. Importantly, the no question means it is not consistent with Alzheimer's disease. A yes would mean it is consistent with Alzheimer's disease, and indeterminate means you could probably use your own judgment there. That could influence your judgment, but here we're trying to document yes, it's consistent with, no, it's not, or if you leave it blank, it's either not applicable or not present. We didn't use it. So same thing for CSF-based biomarkers. Were the results consistent with Alzheimer's disease, supportive of Alzheimer's disease, or help to exclude Alzheimer's disease, in which case we'd mark no, or indeterminate. So that's the section for fluid-based biomarkers. We move into, I'm sorry. There we go. So again, let me highlight a couple of these. Leave it blank if it's not done, or if it's not applicable. No means not consistent with the disease. That's important. And this is an area we need a little feedback on, but if you're marking no, it means it's not consistent with the disease. So, okay, so let's move to imaging now. So was imaging used to assess the etiological diagnosis? If no, we can skip to the next section. But the question is, then if yes, was it PET, SPECT, or MRI imaging or structural imaging? You check both, and the sections will open up. PET, SPECT begins with tracer-based imaging, first to indicate elevation of amyloid or elevation of tau pathology, yes or no. FDG PET, was FDG PET used, yes or no? And if so, is it consistent with Alzheimer's, FTLD, or LBD, or other? And then any other tracer-based imaging can be captured in this question 6D. So if there's advances or people are using and actually, again, using the information to support a diagnosis, then we want to capture that here. And how was it, was it consistent with AD, FTLD, or LBD? So moving into structural imaging, the question here is, was structural imaging data used to support an etiological diagnosis? If yes, then how so? Atrophy pattern consistent with Alzheimer's, atrophy pattern consistent with FTLD, or cerebrovascular disease? If yes, how was it? What were the findings to support cerebrovascular disease? And lastly, for this section, other biomarker modalities, we have this ability to type it in, yes, no, it was used, and what was it, and then what were the results. And then lastly, supportive genetics. This is simplified a little bit from the current form, but the question is, is there an autosomal dominant pathogenic variant to support an etiological diagnosis? So this, if it's Alzheimer's or FTD type genetic variant, you can indicate that here. And that's it, one question. That's part of this simplification of that question was in consideration of some privacy concerns in terms of, having a really small sample size and some concerns that privacy could be breached. And so that's just a simple yes/no question. We're not really getting to the types of genetic, autosomal dominant genetic, which if somebody needs to get to that, there's other ways to get to it. So through other databases and through NACC. So, okay, and then moving to the last section here, the first section is the imaging and biomarkers. Now we're moving into etiological diagnosis. This should look pretty similar. We want this needs to be filled out on everyone. If somebody's unimpaired and they don't have any of these, we leave them blank. But if somebody's unimpaired and has biomarker support and the center per the local standards is diagnosing preclinical Alzheimer's disease, we can mark it as present here. We would leave these blank because they don't have a cognitive impairment. For everybody else, cognitively impaired, and we are making an assessment of what is the etiological diagnosis. Again, this can be done on clinical grounds alone, as it's most commonly done now, or it can be done with the biomarker support that's now been hopefully clearly documented. And so we would mark any of these as present and then assign one a primary diagnosis and others as contributing or not contributing. So this should look pretty similar to the current form. So we have added late here as well, and CAA, which may be in the current form, but that is it. So that's the new form D1b, where again the purpose is assign an etiological diagnosis and indicate when biomarkers are used to support or exclude a diagnosis. And again, not intended to capture biomarker values or start going down that road. It is very complex and complicated. This is all about helping future researchers understand how is that etiology determined or assessed. And again, was it clinical grounds or supported by biomarkers? So I will stop there. Thank you. And
Hey, Jeff, there are a
we'll
few
take
questions. Jeff,
questions.
In the chat. One is about your ApoE results from like 23andMe. I know we had a lot of discussion about people bringing those results to us. You want to speak on that?
Yeah, I mean, we haven't included that here, and ApoE is collected elsewhere, and this is something we may want to reconsider, but at this point we haven't included that. I mean, if it can be used to support a diagnosis, and so maybe we should reconsider that. But the sort of the committee came to the conclusion that's indicated elsewhere. We have it elsewhere, and we can draw on that information, but we want to stay more focused on the fluid and imaging biomarkers. I don't know if anybody else wants to add anything there. Okay. What else do we have?
The question about if FDG PET could be noted to be consistent with the diagnosis, if it could be used across different diagnoses, like DLB versus Alzheimer's.
Yeah, that's a good question. I would say, rely on your judgment, your standards locally. And then I guess if the question is, do mechanics of the form allow that, we'll have to look, because I think you're making a point here that we could be interpreting it as both. And so we wouldn't want to be limiting our choices. And I don't think we do in the mechanics of the form. You can mark two. But I'd say I'd turn that question back to you, John, if you're interpreting it that way. Does anybody else want to comment on this? Cindy, do you have thoughts on that?
Let's see how we have it listed here.
Okay. Greg?
No, I'll say, Jeff, that I think you covered this quite well, that this is that each site needs to use their best clinical judgment in interpreting these biomarkers. So if John felt that the amyloid PET scan or that the FDG PET was consistent with AD, he should check that box. And if he felt that it was consistent with DLB, he should check that box. So I think we have to understand this, amyloid positivity is not just seen in Alzheimer's disease. It can be seen in Lewy body disease as well. So again, what we're trying to do is provide some consistency and to understand when biomarkers were used to support either a pure neuropathologic identity or a mixed multi-etiology degenerative process.
This gets to why, I know there's an earlier question about why we separated out D1 with D1A and B, and it's getting at those ideas of, the clinical presentation, distinguishing it from mixed pathology, which we're finding out is more and more common, and that even if somebody has elevated amyloid, it may not be the prominent pathology that's driving their symptoms.
Just one comment on this. I mean, we were right in the middle of trying to finalize the UDSv4 as the new 2023 revision of the 2018 ATN biomarker-based framework for diagnosis came out. So it was kind of an attempt to integrate where we could. But I think, the field is evolving rapidly to a biomarker-based framework for these diagnoses and coupled with staging. So, we'll try to incorporate that, and I suspect it'll evolve further.
I do think there's a question about other, if you are getting information, say clinically, imaging, blood tests, genetic testing, you have it clinically and it's not research generated. If it's influencing or supporting your etiological diagnosis, we want to indicate that here. So the answer is yes. This doesn't have to be research generated, because the purpose of this form is not to indicate that, somewhere in NACC there's a biomarker value or a sample to support this. This is information that the team at consensus or the clinician at the assessment is using to make that diagnosis and to support that diagnosis.
The field's changing so rapidly. That's why we left this more as, yes, no, indeterminate, because the cut points are going to change. It's just more so, was this present, yes or no, or indeterminate, and, what data was used. So into making those clinical decisions.
And yeah, if you're diagnosing a mixed dementia, you would indicate, the components of that mixed dementia here, and if you have biomarker support, that should be documented. I mean, it should be well documented. If you don't, we would know that you think it's mixed vascular and Alzheimer's or whatever you're diagnosing. So, but you do need to indicate a primary. you know, what do you think is the primary driver? And then I think we should consider the yes, no. We've considered a lot of different, a lot of different terms for, you know, is the biomarker present, yes or no, or consistent or inconsistent. The wording of the questions are worded in a way to hopefully be clear, but we ought to consider inconsistent or consistent. So we'll do that. Thank you, Beth.